Hi, everyone. Welcome to Global Test. My name is Rahul. We do have a Slido question for you. I will start the poll. This is to just let us know where you are from the world. I'll still keep the poll open, which you can also see. And now I'll give the floor to our Dr. Dr. Altar here and Manon.
Everyone, welcome to the first global test of a year. My name is Manon. I hope you can all hear me. I have been working at CellaVision for almost 2 years now, and I'm here today with Dr. Abdul Ghani Alatar, who will do the webinar. But before we start, we will go through some housekeeping information for you. So the first thing is please mute your microphones when you enter the session and do it now if you haven't done it already. And then if you want to ask questions during the presentation, you are very welcome to do so, but in the chat, or please raise your hand because we are a large group. So if you unmute yourself, that will be a problem. So please raise your hand or ask in the chat. And the last thing that we wanted to say is that the session is recorded. You will get the recording by email after the end of the webinar, so around next week at some point. Yes, so I will now introduce my colleague here, Dr. Abdul Ghani Alatar, who has a master's degree in clinical experimental laboratory medicine and a PhD in medical science in the field of hematology and transfusion medicine at Lund University. Dr. Alatar is the author of numerous abstracts, posters, peer-reviewed publications in the field of hematology and transfusion medicine. And here on the PowerPoint, you can see his thesis at Lund University, and there is a link that we will send you so you can have a look at the thesis in details if you are interested. Now I will let my colleague do the presentation. There's a question in the chat, sorry. Do we get certificates of attendance? Yes, you will get certificates once the webinar is finished. You will receive an email next week with all the information. So you will have link to see the recordings, link to Dr. Abdul Ghani Alatar thesis, and also certificates of attendance. Yes.
Thank you, Manon, for the introduction. And first, I would like to welcome you all for joining us today. I also want to thank you for taking the time to complete the test. Your participation is truly appreciated. It was really enjoyable to go through your answers and comments. So now let's take a few minutes to go over some highlights together. Before we start, I would like to briefly clarify a few important points regarding the procedure and the images used in this presentation. The procedure discussed may differ from those in your lab. However, you should always follow your laboratory's policies and procedure. The results of experienced morphologists at CellaVision represented the examiner results, and cell images shown in this presentation were stained with right Giemsa and analyzed on CellaVision DC-1. All the recommendation and guidelines stated during the presentation come from the World Health Organization and International Council for Standardization in Hematology, and unless stated otherwise. So this presentation will walk us through an integrated diagnostics exercise focusing on white blood cells and differential and red blood cell morphology and the interpretation of hematologic malignancies, particularly here acute monocytic leukemia. We will begin with a case presentation where we introduce the clinical context and patient findings, which include a detailed view of the white blood cell differential and red blood cell morphology as assessed by the CellaVision DC-1 system. Next, we will move into the results overview, where we will examine the key findings from the case and then compare how these results align or differ from classification made by participant versus the examiners. We will place special emphasis on white blood cell and RBC classification, discussing common area of discrepancy and why these differences matter in clinical diagnosis and standardization effort. Then we will shift our focus to the disease at the center of this case, acute myeloid leukemia, with a particular look at its monocytic type. In this section, we will cover what AML is and how acute monocytic leukemia is defined, and how accurately diagnose this type, and how it fits into the World Health Organization most recent classification systems. And by the end of this session, you will have a better understanding, hopefully, of all these updates. So let's move on to the case presentation. A child arrived at the urgent care center, visibly exhausted, pale, and weak. For weeks, the child had been battling persistent low-grade fevers, progressive fatigue, and shortness of breath. Symptoms that at first may seem non-specific, but troubling nonetheless. Well, during the clinical examination, the healthcare team noticed additional red flags. The child has gingival swallowing, bleeding gum, and multiple areas of unexplained bruising, signs that point toward an underlying hematologic disorder. Given these concerning findings, the child is urgently referred to the emergency department for further workup. Given these concerning findings, diagnostic investigation became really essential, not just to confirm a diagnosis, but also to initiate potential life-threatening treatments. And to illustrate this, so the complete blood count was ordered at the emergency physician, and what we see here, the result at the counter flagged with abnormal lymphocyte blast cells, thrombocytopenia, and anemia. Let's start reviewing first the examiner classification for this case. According to the differential count provided by the examiner, approximately 45% of the white blood cells were classified as lymphocytes. Of course, this reflects a significant lymphocytic component, which could suggest either reactive process or, in some cases, an underlying lymphoproliferative disorder, depending on the clinical context. In addition, 51% of the cells were classified within the promonocyte to monocyte range. This is particularly important as distinguishing between immature monocyte and blast, especially promonocytes, can be diagnostically challenging and carry significant implication for identifying acute monocytic or myelomonocytic leukemias. Turning to the red blood cells morphology, the smear revealed the presence of chenocytes, also known as PER cells, which are often associated with renal disease, artifact, or electrolyte imbalance. Alongside this, there was evidence of poikilocytosis, indicating a broad variation in red blood cell shape, a common feature in condition causing bone marrow stress or ineffective erythropoiesis. Together, these findings suggest a dysregulated hematopoietic environment, warranting further investigation through cytochemistry, immunophenotyping, and molecular testing. Now, let's move to your results. We were happy to see that almost 828 participants have signed the test. And the result of CellaVision examiner largely agreed with the group of the majority, as you can see here, both in terms of white blood cells differential and red blood cell morphology. This is really encouraging to start with. However, one of the main areas of disagreement stood out clearly is the monocyte population. This classification of monocyte continue to be one of the challenging area in hematologic morphology. So this misclassification can significantly impact diagnostic outcome, particularly in acute leukemia with monocytic differentiation. In addition to that, during the case comment process, we noticed that many participants relied on the older classification system of leukemia. While this system provides a solid foundation in the past, it is important to note that our understanding and classification of hematologic malignancy have evolved, especially with the latest update from the WHO and the International Consensus Classification, ICC. So, as we continue, we will take a deeper dive into this modern classification framework, highlight the key changes, and discuss why it is essential to adapt them both in practice and training. Monocyte. So let's take a look at the key morphological distinction between monoblast, promonocyte, and monocyte. Starting with the nuclear shape, monoblasts typically have a round to oval nucleus. As they mature into promonocytes, the nucleus becomes delicately folded and convoluted. By the time the cell reaches the monocyte stage, the nuclear shape is more prominently convoluted. Moving to the chromatin characteristics, monoblasts display delicate lace-like chromatin with one or more visible nuclei. Promonocytes retain this lace-like appearance but show visible nuclei. In contrast, monocytes exhibit condensed chromatin with small, less distinct nuclei. For the cytoplasm, monoblasts are moderately to intensely basophilic, often containing rare azophilic granula and cytoplasmic vacuoles, while promonocytes have a blue-gray cytoplasm with a visible azophilic granula and sometimes vacuoles. Moving to the monocyte, being more mature, show increased vocalization and more pronounced granules. Finally, in terms of size and comments, monoblasts are medium to large in size, ranging from 20 to 30 micron, while promonocytes are noted to be very similar in appearance to monocytes, while still large, 20 to 25 micron, are more differentiated. So based on this, we have prepared a short quiz that we will go through together at the end of presentation. So it's a great way to recap the key points that we covered. You can start by either scanning the barcode or the link in the chat. So let me walk you through this figure. It looks complex, but it is really brief as well. So it is about myeloid development and leukemic cell origin. So to start with, the normal process of myeloid cell development and how it relates to leukemic transformation and leukemic stem cells is very important to clarify. So let's begin with from the left-hand side, where we will see the maybe I can see a pointer here, so I can. Perfect. So the left-hand side, you will see the multi-potential stem and progenitor cells shown in blue. These include the long-term repopulating stem cells, short-term repopulating stem cell, and multipotent progenitors. These are the earliest and most flexible cells in the hematopoietic hierarchy, capable of giving rise to all blood cell type. However, it's a center of debate for many researchers. So every researcher has their own criteria to classify it, and say which one comes first and which one more important. So, but we'll leave it that to the scientific research. So these are the earliest and most flexible cells in the hematopoietic hierarchy, capable of giving rise to all blood cell types. Moving forward toward the center, you can see we shift to the committed progenitor cells, which are highlighted here in yellow. These include the common myeloid progenitor and their downstream derivative, granulocyte, macrophage progenitor, megakaryocyte, erythroid, and colony-forming units like the CFU-G and CFU-Ms and CFU-Es and CFU megakaryocytes. These cells have more restricted developmental potential and are more programmed to become specific type of blood. On the right, you will see the differentiating myeloid cells, which are now morphologically recognizable, granulocyte, macrophage, erythrocyte, and megakaryocyte. Now let's focus on the red boxes here, which mark the malignant cell associated with acute and chronic myeloid leukemia. In acute myeloid leukemia, the leukemic blast mirror normal myeloid blast at various stages, each representing a block at a different point in differentiation. In contrast, chronic myeloid leukemia primarily involved terminally differentiated granulocyte during the chronic phase. Finally, and most critically, notice the blue boxes highlighting the leukemic stem cells to the left. These are rare cells that drive disease initiation and relapse. In summary, this figure captures the complexity of normal myeloid development and overlay the key steps where leukemic cells and stem cell hijack the process, offering insight into both pathogenesis and potential therapeutic target. Now, let's move to the what is AML? So it is a clonal hematopoietic malignancy characterized by overproduction of immature myeloid cells, blast, with a block in differentiation, where the blasts are the malignant cell in acute leukemia and characterized by a non-terminally differentiated hematopoietic cells in a very simple way. So let's move to the next point and review the World Health Organization classification of hematolymphoid tumor. In this edition, they integrate morphologic, immunophenotypic, genetic, and clinical feature, moving beyond the traditional morphology alone. It provides clearer guidance on the use of genomic data in classification and prognosis, which is especially important in the era of precision medicine. Now let's take a closer look at the WHO classification of acute myeloid leukemia, as outlined in this edition. AML is now grouped into two main categories. And the first major category is AML with defining genetic abnormalities. This category reflects a modern shift in classification, which genetic and molecular feature take over a plus percentage. In fact, many of defining abnormalities in this group no longer require the traditional 20% plus threshold for diagnosis. Within this category, there's an important subcategory known as AML myelodysplasia related. But in this case, the diagnosis still does require at least 20% plus. AML myelodysplasia related is diagnosed based on three key criteria: molecular abnormalities, such as gene mutation associated with poor prognosis, cytogenic abnormalities, including complex or specific chromosomal changes, and a prior clinical history of myelodysplastic syndrome or myeloproliferative neoplasm. This group includes cases of AML that don't meet the genetic criteria we discussed previously, but instead are diagnosed based on morphology and require the classic threshold of 20% plus in the bone marrow or peripheral blood. These cases are identified by the lineage and maturation of leukemic cells. Now, a part of these two main categories, the WHO introduced a separate group for secondary myeloid neoplasm. This group includes both cytotoxic therapy, referring to AML that develop as consequences of prior chemotherapy or radiation, often with poor prognosis due to therapy-related genetic instability, and myeloid neoplasma associated with germline predisposition, which this occur in patients with inherited genetic mutation, placing them at higher risk for developing leukemia, often at younger age or in familial clusters. Recognizing this distinct secondary form is essential, as they often require different management strategies, genetic counseling, and consideration for family screening in case of germline involvement. Together, these categories make the new classification more comprehensive, reflecting both biologic diversity and clinical context in the diagnosis and selecting the accurate treatment of AML. Now let's turn our attention to the differentiation-based classification of acute myeloid leukemia in the same edition, where diagnosis is grounded in morphological feature and immunophenotypic markers. In this WHO-defined group, AML is diagnosed when blast makes up more than 20% of the bone marrow or peripheral blood, and the leukemic cells show evidence of myeloid differentiation, either morphologically or through specific marker expression patterns. I will not go through all these groups, but I will briefly summarize the highlight of it. So to support this classification, we rely on differentiation marker that helps identify the lineage and maturation stage of the blast. This include myeloid marker like CD13, CD33, and myeloperoxidase, and monocyte markers such as CD14, CD64, and CD11C, and non-specific esterase positivity, and erythroid or megakaryocyte marker in rare subtypes. Now let's take a closer look at our diagnostic finding from our case. So we saw that the blood smear revealed numerous monoblast and promonocyte, which are classified as blast. This is a key indication of acute monocytic or monoblastic leukemia. Additionally, the patient showed sign of anemia and thrombocytopenia, consistent with disease-related myelosuppression, suggesting that the bone marrow is significantly affected by the leukemic process. And from the genetic standpoint, two important findings were observed: a translocation T611, which involves the KMT2A gene, commonly associated with poor prognosis in AML, and the presence of an FLT3 ITD mutation, another high risk. While the immunophenotypic results provide further confirmation showing a distinct marker profile, the positive ones were CD4, CD11B, CD11C, 13, 33, 45, 56, and 64. And the negative CD2, 7, 11, and CD34 and CD11, 117. And the HLA-DR was also expressed. So these immunophenotypic patterns support the diagnosis and help to characterize the leukemic blast. So let's go back to our table provided by the WHO. So we see that we have a couple of them. couple of the features that overlap with acute monocytic leukemia category. To make the diagnosis, to make this diagnosis, the bone marrow or peripheral blood must show 80% or more monocyte, according to the new characterization, and or their precursor, which include monoblast and promonocyte. In contrast, there should be less than 20% of maturing granulocyte cells, helping to distinguish it from other AML subtype with more granulocytic differentiation. And when it comes to the diagnostic marker, blast and promonocyte must express at least 2 monocytic surface antigen, a common marker, either CD11C, 14, 36, and CD64. These markers are crucial in confirming monocytic lineage using flow cytometry. Alternatively, if the immunophenotyping is inconclusive or unavailable, non-specific esterase positivity on cytochemical staining can provide supportive evidence for the diagnosis. All this together, identifying this feature help accurately classifying the leukemia and guide the next step in management. If going back to our case, we see that based on all this information, the morphology, immunophenotypic, genetic finding, and diagnostic that used in the diagnostic, we can confidently conclude that our case is acute monocytic leukemia. The predominance of monoblast and promonocyte, the expression of key monocytic marker, and the supportive genetic profile all align with this diagnosis. This classification is crucial not only for accurate diagnosis, but also for informing prognosis and guiding appropriate treatment decision moving forward. To wrap up, let's briefly summarize the new update from the WHO classification of acute myeloid leukemia as outlined in the latest edition. The classification framework has undergone a minor shift from AML. So AML now is divided into 2 main categories: AML with defining genetic abnormalities and AML defined by differentiation. One of the most significant changes is the increased emphasis on genetic feature rather than solely relying on the blast count for making a diagnosis. This reflects our growing understanding of the molecular drivers of the leukemia and aim to enhance diagnostic precision and treatment personalizations. So in short, this update brings more genomically driven approach to AML classification, setting a new standard for how we diagnose and manage the disease moving forward. And this is all, of course, reflect a precision medicine approach where we integrate genetics, morphology, and clinical context to refine AML diagnosis and management. So let's move on now to your questions again to see how we have done there. Let's start with the first question. Which stage of monocyte development is characterized by a round or oval nuclear? Yes, we are happy to see the majority of you answered the question correct. What is a distinguishing feature of the cytoplasm in mature monocyte? Correct. Well done. Which developmental stage has a convoluted or intended nucleus, moderately basophilic cytoplasm, and a more condensed chromatin with a rare nucleus? Perfect. That's correct. The majority is correct. What is the typical size range of monocyte? Yes, that's correct. The majority is correct. And the last question in this category, which of the following best describe a promonocytic cytoplasm? Perfect. The majority also correct here. Well done. And we have the last question, more on the new classification terminology. And I'm happy to hear that, yes, the majority answered correct here. Perfect. Well done. Yes, with that, we can conclude and we'll thank you all.
If you have any question, please feel free to raise your hand or ask in the chat. Has the blast threshold been dropped from overclassification as well? Example all.
I haven't looked at those actually, but I can share the guideline book with you all, so you can have a look actually at all the new WHO classification. Just so I give you an accurate answer. Yeah.
And another question just arrived. Will recorded video for this session be available? And the answer is yes. We will send you the recorded video by email during next week, and you will be also able to find it on our website along with the previous webinar recordings. Why have we suppressed the monoblastic AML?
That's good questions. I think it's mainly because since the new classification now actually makes it as a combine talking morphologically, that we combine the promonocyte, we consider them as blast. So actually that's probably the main, to avoid any confusion probably, and also these the phenotypic characterization of it also was one of the reason, I guess.
Question: is it okay to integrate both FAB and WHO classification in diagnosis?
Well, as I know, in many places they still use the FAB. So, but as long as both are reported, that should be fine, I guess. But not only FAB.
What about promonocytes in our case? Are they promonocytes?
Yes. The simple answer. But if we counted them as blast here according to the WHO. So yes, they are very distinct in our case here. Yeah.
All right. Thank you all for joining us today. We will end the webinar now. As mentioned before, you will receive a recording next week, and please stay tuned for our next webinars. We will have, of course, a global test during the year. So yes, we hope to see you there. Thank you all. Bye.
Thank you too. Bye.